Okay, let's unpack this. Imagine you're in the thick of it, exams looming, or a complex case right in front of you. Today, we're diving deep into a condition that definitely tests your skills. Adult Perthes Hip.
It's a really crucial topic.
Absolutely. And this deep dive is based on the fantastic Ortho Made Simple notes you can find on mokyingren.sg. They were put together by Dr. Mok Ying Ren, who's a sports surgeon over at National University Hospital in Singapore. He aced his FRCS back in 2022.
Yes. Excellent resource.
Our goal here is pretty clear. Boil down the absolute must-knows on diagnosing, classifying, and managing adult Perthes. We want you feeling confident, ready for those postgraduate exit exams like the FRCS, and sharp in your clinical practice, too.
And adult Perthes, it really does throw some unique challenges your way, doesn't it? It's quite different from the pediatric form we often think about first.
How?
Well, it demands a really nuanced understanding, both the diagnostic signs and how you tailor the management, getting the pathology identified correctly, and planning surgery meticulously. It's not just helpful, it's absolutely fundamental for the patient's long-term outcome, especially with the kind of structural changes we often see.
That really sets the scene. Okay, so let's start where we usually do with the visuals. When you pull up an X-ray, what are those definitive signs, those radiographic signatures of adult Perthes that should make you set up and take notice? Is there like a special sign we need to look out for?
Definitely. On the plain films, the first thing you'll likely notice is a deformed femoral head. And it's not just vaguely deformed, it often presents in specific ways. You might see it enlarged, that's coxa magna, or it could be quite flattened, which we call coxa plana.
Okay, magna or plana.
Exactly. And alongside that, you often find the femoral neck is short, coxa breva. And frequently there's coxa vara, so that neck shaft angle is decreased.
Got it.
But the one sign that's really characteristic, almost like a fingerprint, and something examiners love to ask about, is the sagging rope sign.
The sagging rope sign. Okay, that sounds distinctive. What exactly is it telling us? Why is that one so special compared to, say, just seeing a flattened head?
Well, the sagging rope sign is really insightful because it's a direct visual clue about the history of the disease. It points to the reossification process that happened after the initial avascular necrosis way back when the patient had Perthes as a child.
Ah, so it's like a scar from the past?
Precisely. It signifies this specific pattern of collapse and sclerosis, usually seen along the inferior part of the femoral neck. It's not just general wear and tear, it's evidence of that specific healing response. That helps distinguish it from, say, primary osteoarthritis, which has a different origin story. It's a strong clue for adult Perthes.
That makes sense. It points back to the childhood disease. So when we see these features, the deformed head, maybe the sagging rope sign, how do we classify them? How do we communicate the severity and what it means for the patient down the line?
Right, classification is key here. We primarily use the Stulberg classification system for that. It's crucial because it links the radiographic appearance, specifically the hip joint's congruency, to the patient's likely future. Their function, pain levels, risk of developing bad osteoarthritis later on.
And which Stulberg types are most relevant for adult Perthes?
For adult Perthes, we're really zeroing in on types 3, 4, and 5. Type 3 means the head is aspherical, not perfectly round, but it still fits reasonably well into the socket. It's congruent. Type 4, that's where you have that significantly flattened head we talked about.
Coxa plana.
Yes. And type 5 is where things are really out of whack. The hip is incongruent. The head and the socket just don't match up properly anymore. Understanding these types isn't just academic. It's vital for predicting the prognosis and figuring out the best management plan. Are we aiming for joint preservation, or is a replacement likely needed?
So Stulberg gives us that essential framework for prognosis and planning. But, medicine loves its mimics. Before we absolutely nail down adult Perthes based on the x-rays, what else should be on our radar? What are the big differential diagnoses we need to rule out, especially in an exam setting?
Excellent point. Clinical vigilance is paramount here. When you see those x-ray changes, the two big things you must consider and rule out are significant trauma and, critically, infection.
Trauma and infection.
Yeah, both can cause changes in bone shape, pain, and limb function. You need a really good history, a careful exam, and sometimes more tests, labs, maybe other imaging to tease them apart. Missing an infection, well, that could be disastrous.
A critical point. Keep the differential broad initially. Okay, so we've got the x-ray clues, we've thought about the mimics, let's connect it to the patient standing or walking in front of us. What does the physical examination typically reveal? What story does the body tell that reinforces our suspicion of adult Perthes? Are there any common pitfalls here?
There is actually a potential pitfall. or maybe just something slightly counterintuitive. Adult Perthes, especially the chronic form in adults, can sometimes be surprisingly, well, painless. Or the pain might seem quite mild given how bad the x-ray looks.
Really, less pain than you'd expect.
Sometimes, yes, and that can throw you off if you're only looking for severe pain. So the insight here is you have to look beyond just the pain score. Focus hard on the functional limitations.
Okay, so what functional signs are we looking for?
Gait abnormalities are almost always there. You might see a clear Trendelenburg gait, that characteristic hip drop showing the abductor muscles are weak, or perhaps a short limb gait.
How does that look?
The patient might bolt, kind of hike themselves over the affected leg, or walk on their tiptoes on the shorter side to compensate. You'll also usually find stiffness, a limited range of motion in the hip,
Yeah.
and often muscle wasting. Look at the glutes and thigh muscles.
It's atrophy, right.
Exactly. When the patient's lying supine, check the leg's attitude. It might naturally lie in external rotation. And limb shortening is very common. So you need to do your leg length discrepancy test, Galeazzi's, Bryant's triangle, to measure it properly.
Galeazzi and Bryant's. Check.
And don't forget Thomas's test. That's crucial for picking up any fixed flexion deformity, which is often present, and messes up their gait and comfort quite a bit. These functional signs are key, especially if pain isn't the main complaint.
That really underscores the need for a detailed, hands-on exam. So we have x-rays, clinical findings. What about other investigations? If we're thinking surgery might be needed, what else helps us plan?
If surgery is potentially on the table, a CT scan becomes really valuable. Its main job is to give us that detailed 3D picture of the bone stock.
Bone stock assessment.
Precisely. In a Perthes hip, the anatomy can be seriously distorted. So knowing the exact shape, quantity, and quality of bone in both the acetabulum and the femur is critical before you go in. It helps you plan exactly where implants will go and ensure they'll be stable.
Makes sense. And just to circle back and make sure we're all on the same page, the classification system we're using to grade this and guide prognosis is still Stulberg, correct?
Yes, absolutely. Stulberg's remains the gold standard, the definitive classification for assessing radiographic severity and predicting the likely outcome in adult Perthes hip. It's the common language we use.
Okay, perfect. We've really built a solid picture now from those x-ray signs like the sagging rope through the Stulberg types, the clinical exam nuances like painless limitation, and the need for CT planning. Remember, this deep dive is grounded in the Ortho Made Simple notes from mokyingren.sg. So with that diagnostic foundation, let's talk solutions. What are the management strategies? Is surgery always the answer?
No, not necessarily. Non-operative management definitely has its place. It's a good option for patients with minimal symptoms, perhaps those with a more congruent joint, maybe a Stulberg type 3, who are functioning reasonably well.
And what does that involve?
Usually things like activity modification, avoiding high-impact stuff, pain management, maybe NSAIDs if needed. And physical therapy is key, working on range of motion, strengthening those supporting muscles, especially the abductors, trying to optimize the hip they have.
Okay. But what about younger patients where maybe things are progressing or the hip is unstable?
Right. For younger patients, especially if there's instability, like lateral subluxation of the femoral head, then surgery is often considered. The goal here is usually joint preservation, trying to improve the hip's mechanics to delay or prevent arthritis.
And what kind of surgery are we talking about?
Typically, we're looking at osteotomies. A pelvic osteotomy is common, specifically the Bernese periacetabular osteotomy, or PAO. It's quite versatile.
Why the Bernese PAO?
Because it allows you to reorient the patient's own acetabulum in multiple directions. You can get better coverage over that often misshapen aspherical femoral head, improving the congruency and low distribution. That's really the aim in these younger folks. Sometimes you might also do a proximal femoral osteotomy, maybe to correct a significant varus deformity if that's part of the problem.
Improving containment and congruency. Got it. Now, let's shift gears to what I suspect is often the really high-pressure scenario for residents in exams. The complex primary hip, this is usually older patients, or those with really severe secondary OA from their Perthes. What makes this so complex, and what do residents need to know, Cold?
Ah, yes, the complex primary. This is definitely a step up from a routine hip replacement. It requires incredibly careful planning and execution right across the board, pre-op, intra-op, and post-op.
Let's break that down preoperatively.
Pre-op planning is everything. You must template meticulously. Pay close attention to that leg length discrepancy, the LLD. You fully expect the Perthes side to be short, so your plan needs to include how much you're going to lengthen, aiming for maybe slight lengthening to restore balance, but doing it safely.
Controlled lengthening.
Exactly. And honestly, for these cases, having senior surgeon backup available is non-negotiable. Things can get tricky fast. You also need to plan your fixation strategy. Often, hybrid fixation is the way to go.
Hybrid meaning.
Typically an uncemented cup on the acetabular side, aiming for biological fixation, paired with a cemented stem on the femoral side. The cemented stem can be more forgiving and reliable when dealing with the potentially weird femoral canal anatomy you often find in Perthes.
Okay, meticulous templating, senior backup, plan for hybrid fixation. What about intraoperatively? What are the big challenges there?
Intra-op, you need to be ready for a tougher exposure. Often you'll need an extensile approach, maybe even a trochanteric osteotomy.
Taking the trochanter off.
Temporarily, yes. Because the anatomy is often so distorted, maybe scarred down from previous surgery or just the disease itself, standard approaches might not give you the view or access you need. Taking the greater trochanter off and reattacking it later gives you much better exposure. Dislocating the hip itself can be a real battle, especially if there's been prior surgery. Expect contractures, weird anatomy.
Any tips for a difficult dislocation?
One pearl is sometimes doing the femoral neck cut first can actually help you gain mobility to dislocate it. And if you encounter tight, soft tissues, you'll need to release them. Specifically, think about the gluteus maximus insertion and the psoas tendon.
Okay, get exposure, manage the dislocation. What about putting the parts in?
Finding the true acetabulum is critical. The anatomy can be shallow or distorted. Your key landmark here is the transverse acetabular ligament, the tail. Use that to find the floor and the correct level.
Don't get lost in a false acetabulum.
Precisely. Then, placing the cup needs to be spot on, aiming for those Lewinnek safe zones. That's an inclination of 40 degrees plus or minus 10 degrees.
40 plus or minus 10.
An anteversion of 15 degrees plus or minus 10 degrees. You really need to hit these numbers. Being outside the zone drastically increases risks like dislocation, impingement, early wear, vital in these complex cases.
And the stem?
Usually a standard cemented stem, again paying close attention to getting the right anteversion and depth, seating it well in the cement within that potentially abnormal femoral canal, and post-operatively, standard hip precautions followed diligently.
Wow. Okay. That paints a very clear picture of why it's called a complex primary. So let's pull this all together. What's the big takeaway for you, the resident tuning in? We've journeyed through adult Perthes Hip, the X-ray signs, the Stolberg types, the sometimes subtle clinical exam, and these really intricate management options. Grasping these details, especially the why behind the surgical steps, is what boosts your exam readiness and, more importantly, your confidence in practice.
Absolutely, and maybe connecting it to the bigger picture. What cases like adult Perthes really highlight is that every patient is a unique puzzle, right? Especially with these complex conditions. The skill lies in synthesizing all this information, the imaging, the exam, the surgical principles, and applying it critically, adapting your plan to that specific patient's anatomy and pathology. It's really a continuous learning process, taking knowledge from resources like these notes and translating it into excellent patient care. It's about mastering both the science and the art of orthopedics.
Well said. This deep dive into adult Perthes Hip was based on the incredibly useful Ortho-made simple notes available over at mokyingren.sg. As you continue your journey, tackling complex cases and expanding your knowledge, remember that true mastery comes from discipline and a love for learning. Keep pushing, keep questioning, and keep refining your skills. May your dedication and your studies be blessed.